Is our presentation for making life easier with assess, prepare, treat and surgical wounds. Next slide, please, Abby. So the objectives of today's session is, during the session, we're going to introduce you to our Coloplast three-step approach, which is a step-by-step framework to effectively assess, prepare and treat surgical wounds. Hopefully, by the end of the webinar, you will learn a simplified approach to wound healing, understand the impact of surgical wounds and surgical wound breakdown or wound dehiscence, gain an overview of the latest recommendations from the National Wound Care Strategy Programme in regards to the prevention, identification and management of surgical wound dehiscence, and leave with the Coloplast three-step approach non-healing surgical wound pathway to support your practice. Next slide, please. So there's a huge burden of wounds in the UK. We've got roughly about 3.8 million patients with a wound in the NHS which are managed annually, which is an average cost of to be estimated about 2.7 billion, and 30% of these wounds do not heal. It is estimated that 59% of chronic wounds healed if there's no evidence of infection, with 45% if there is a suspected or a definite infection. Biofilm in chronic wounds is seen in about 80% of wounds, and 46% of healthcare professionals believe that infection is a challenge when treating wounds, and this also covers surgical wounds as well, because we can get surgical site infections. Next slide, please. So just an overview of surgical wounds. It's estimated that 52% of the cost of acute wounds is attributed to surgical wounds, and caring for surgical wounds in primary care accounts for 18.9 to 21.8 of the total wound care expenditure of the NHS. So if you think of these wounds are supposed to be quite simple and heal quite quickly due to their nature, it's quite a significant cost that's associated with treating them in primary care. Most surgical wounds do heal without complications or delay, but some don't, and it affects the clinical outcomes and the patient's quality of life. If you think about, if you've had a surgical wound before, if you've had a C-section, that wound then breaks down, you are in quite a lot of pain, it affects your quality of life, you can't kind of bond with your baby, things like that. It's important that we raise awareness, improve identification and prevention and management, and it will help these negative impacts of these patients' quality of life associated with healthcare costs. There is evidence to suggest that there is a suboptimal approach to care when complications occur. People don't quite know how to deal with them, because by nature they should heal quite quickly. Due to the need for earlier discharge and post-operative, most complications do occur in the community. If you think of all these enhanced care pathways, most patients do have surgery and are discharged quite quickly. Early interventions as well as healthcare professional education is key to preventing these escalations and deterioration severity, and allowing patients to have more accurate and timely treatment. Next slide, please, Abby. So wounds can heal by two intentions. So primary intention is closing the wound within an hour of injury, and it's where the wound edges can be brought together quite easily without tension. And this is what you do normally see in your surgical wounds, where they're brought together with either staples or stitches. Uncomplicated acute wounds generally heal by primary intention as well, so skin tears, your normal cuts and grazes, things like that. They're not suitable for long-term chronic wounds or those with a large cavity. So if you've had surgery and you've had quite a large abdomen and abdominal surgery, then normally these wounds will be left to kind of heal by secondary intention, which is what we'll come on to now. Next slide, please, Abby. So secondary intention, when the primary intention is not possible, and wounds should be left to heal, open to heal spontaneously through contraction and reepithelialization. This is where we kind of heal from the bottom up. They're used in your hard to heal wounds, like I mentioned, and it's allowing the body to naturally heal from the base up. During this process of secondary intention, the wound can transition between healing stages if infections or biofilms occur, and complex wounds should be monitored closely. So in acute wounds, for example, if you look at that bottom photo, it's the wounds that have maybe had a larger area of the body has been kind of operated on with a larger open area. So the wounds need to heal from the bottom up, because otherwise if you kind of pull them close, they'll break open because of the tension. Next slide, please. This is our Coloplast 3-step approach, and it's to simplify wound healing. So step 1, we've got assess. So you will perform a holistic and wound assessment is paramount in defining the treatment objective. So you'll look at everything, the whole patient, not just the hole in the patient. Sorry, my computer's just froze. So you would look at the holistic and wound assessment. You would look at the whole patient, you would look at their risk factors, you would look at their past medical history, and you do a wound assessment as well, using the triangle of wound assessment. You'd look at the wound bed, the wound edge, and the peri-wound skin. Step 2 is prepare, and wound preparation is key to removing the barriers to healing and creates an optimum healing environment. And you even want to do this with your surgical wounds as well. You want to make sure that these wounds are clean from any sources of infection, any issues that might cause an infection or anything like that. And then step 2, you want to go on to treat. You want a simplified dressing to manage the wound and depth at any stage of healing. Next slide, please. So what we'll do is we'll do step 1, and we'll do what we're kind of looking for in a wound assessment when it comes to a surgical wound. So for a surgical wound, when you are doing the wound assessment, you want to know what the cause of the skin breakdown was. So we do know that it's a surgical wound, but what was the reason of why they had the surgery in the first place? Was it planned? Was it an emergency? Because that can also affect the healing as well. With a planned surgery, obviously you have your risk assessment, you have your pre-op assessment and things like that, and the patient's a bit more aware of the aftercare. Whereas with an emergency, it's a bit more dire, and the patient is usually rushed into theatre. You want to kind of know what their associated risk factors are. So are they diabetic? Do they have COPD? Are they on any steroids? Have they had surgery for any sort of cancers or anything like that? Because that could all affect the healing as well. You want to correct and treat any underlying causes as well. So if they've had surgery because they've had something like necrotizing fasciitis, for example, you might want to kind of look at whole infection markers and look at other options. You want to identify the appropriate management options as well, because one size doesn't suit all. You want to control any wound-related symptoms. So have they got increased exudate? Have they got pain? You want to be looking at elements like that. You want to prevent further skin and wound deterioration. You want to be looking at your exudate management to stop the wound, the exudate going onto the wound bed or the peri-wound skin. You want to know what the patient's expectations are as well. Are they expecting this wound to heal quite quickly? Do they think that it's going to be more slower? And again, that'll come with identifying the cause of what the surgery was for in the first place. And you also want to be providing your psychosocial support and promoting patient independence, getting them to do elements of self-supported self-management, getting them to look for signs of infection, even maybe getting them to do some dressing changes if it's possible and it is a simple surgical wound. Next slide, please. So as I've mentioned, when we do our wound assessment, we want to be looking at the triangle of wound assessment. It's a holistic wound assessment framework to assess and manage all areas of the wound. So we were looking at the wound bed, the wound edge, and the peri-wound skin. Next slide. So for your wound bed assessment, you want to be looking for any necrotic tissue, and especially in surgical wounds, this kind of be a flag for you to seek some support maybe from the surgical team. Is the wound sloughy? Is it starting to kind of break down a little bit, or have you got granulating and epithelialization tissue there? You also want to be thinking about what the exudate volumes are like. Are they low? Is it dry completely? Is it quite high? And because that could all be an indicator of an infection. What's the consistency of the exudate as well? Is it thin and watery, or is it quite thick and purulent? And the colour as well. Is it clear, purulent, like I've just said, or is it pink or red? because they could all indicate signs that you maybe need to seek kind of advice from the surgical team. Next slide. Moving on to your wound edge assessment, you want to be looking at the edge of the wound. You want to be looking for any signs of maceration, because that could identify that those exudate volumes are quite high. Dehydration, the cells won't be able to kind of epithelialize over and close the wound if they're too dry. We want that wound area and the wound bed and the wound edge to be quite moist. Is there any undermining? Because if you're kind of wanting to heal by secondary intention, you need to make sure that the undermining is kind of also adjusted as well. And any rolled edges, which you probably won't see in surgical wounds. And if you do see in surgical wounds, it's probably an indicator that it needs a review and maybe some further testing. Next slide, please. And then your peri-wound skin. So this is the third area of your triangle. So again, you're looking for maceration. This can be an indicator that the exudate levels are too high. You may have some excoriation. So this could occur if you've maybe got a surgical wound that's maybe close to a stoma site, and the contents of the stoma have maybe leaked out, because you do find them in abdominal surgery where they are quite close together. Have you got any dry skin? Dry skin can obviously cause a break in the structure of our skin, which can allow microorganisms to get in, which then could increase the risk of infection. And then you might not see kind of hyperkeratosis and callus as much in your surgical wounds, but they are causes that you maybe need to look at in the peri-wound skin assessment, because it will affect your treatment choice. Next slide, please. So surgical site infections. Delayed healing in surgical wounds is commonly associated with surgical site infections, and you will normally see this abbreviated to SSI. The clinical symptoms do usually occur within 7 to 10 days, and 50% of these become evident after discharge from the acute services. So you will be seeing these in kind of community and primary care. All surgical site infections should be reported up to 30 days post-operatively. So this should be done by whatever kind of incident monitoring or anything that you use in your practice. And if implants have been involved, this should be up to 90 days after. There's a massive drive for orthopedic surgeries to be reported regardless of time, and that's kind of being reported nationally. So the signs of infections that you need to be looking out for is local infection, so signs of local warmth, erythema, so redness around the acute wound site, any swelling, any increase or purulent exudate, delayed healing, and friable granulation tissue. So is the wound bleeding quite easily when you touch it? And spreading and systemic infections, is that redness or that erythema really spread, and is it really kind of going past the peri-wound skin? Has the patient got pyrexia? Have they got a temperature? Is there kind of like an abscess or a pus now around the wound, and is the wound completely broken down? Next slide. One of the main issues that you can have with surgical wounds, if they've been healed with primary intention, can be dehiscence, and this refers to the separation of the margins in a surgically closed wound. So this can happen when whatever materials has been used to close the wound have been removed. So if you've got your staples or your sutures, they've been holding the wound together. Once you remove them, the wound then breaks down and opens up. They can be caused by a surgical wound, surgical site infection. However, they can be caused also by hematomas under the skin, mechanical stress. So if somebody hasn't kind of gone by their post-op instructions and they have been told not to lift heavily for so many weeks, they've obviously not gone and abided by that and done it, and they can break the wound open. Obesity is also a risk factor for surgical wound dehiscence, and in planned surgeries, this is normally kind of highlighted as a factor, and they may have other treatment options, but it still doesn't mean that they're completely fine after that risk assessment. Or any pre-existing chronic disease states that just may help delay healing. It's critical to determine the extent of the dehiscence as soon as possible, and whether or not the wound requires secondary intention to heal, so that where we would look at healing from the bottom up, or whether or not the surgical team need to re-intervene and go back into surgery and close it further. Next slide, please. If a surgical wound breakdown is identified and recognised as early as possible, outcomes can be improved. An accurate and thorough clinical assessment should be used as soon as possible. So you need to be doing this at every dressing change, and really using a thorough clinical assessment to make sure that you can set this patient on the right path. Next slide, please. So the National Wound Care Strategy Programme recommendations for surgical wounds. So these are the red flags that you need to be looking out for. So if you've got a hemorrhage or a catastrophic dehiscence, so if you've got a burst abdomen, you can see visible internal organs, you need to treat this as an emergency. You need to ring 999 and get this patient kind of back into the acute services as quickly as possible. If you've got signs of systematic infection or sepsis, you want to obviously follow your NICE guidelines, but you want to arrange for an immediate review by a senior clinical decision maker, whether or not this is whether it's back within the acute services under the acute surgical team or in your local practice. If you've got signs of spreading cellulitis or dehiscence, if the surgery involves implants or your meshes, or it's aesthetically or functionally important to the surgical site, so your face or your joints, you want to get that wound reviewed by the surgical team within 24 hours. If the dehiscence exposes subcutaneous layers of fascia, you've got a suspected sinus, fistula, or any tunneling, or you've got a stoma within the wound boundary. So if you've got a stoma within that peri-wound skin, you want to be kind of getting the review from the surgical team within 72 hours. Next slide, please. So that was wound assessment. So if you've looked at the whole wound, you've done a holistic assessment and a wound assessment, you can then move on to kind of step 2, which is prepare, and which will then lead on to treat. Next slide. So this is step 2, which is prepare. Slough, non-viable tissue and biofilms can all delay the wound healing process, as they can increase the risk of infection, inhibit development of healthy tissue, limit your wound assessment. So in your surgical wound, you don't want to increase any risk of infection further, because it will help that wound to heal and come together. They've already got one risk of infection from having the surgery in the first place, because even though they're done in sterile environments, you are still causing a break in the skin, which can increase the risk of infection. It also inhibits your wound assessment, because if you've got slough and non-viable tissue in there, what are you actually looking at? That's what you're looking at. You're not looking at what the wound bed is actually appearing as. So you need to get rid of that and to have a proper wound assessment and actually see what the wound bed is like. Because if you've got slough there, it can look 100% covered in slough, it can be quite yellow. But once you kind of clear it away, it would be 100% granulation tissue, and it does then determine and change what your treatment option would be. And we know from research that's done that 80% of non-healing wounds contain biofilms, and that goes for surgical wounds as well. So if you've got a surgical wound that's kind of non-healing and broaching on about 2 weeks old, there is a chance there that you can you will have a biofilm present. Next slide, please. The Wilcox study was a study that was done a few years back, and it clinically proven that cleansing and debridement can speed up wound healing. Preparing the wound by cleansing and debriding prior to applying the dressing has positive results and speeds up wound healing. So the results that are on the screen are related to a diabetic foot ulcer, and there is times when these wounds do need to go and have surgical debridement done because of the nature. They might have needed an amputation because the foot ulcer got too extreme. And what you can see from the results that are on the slide is that those wounds that were debrided at least once every 2 weeks had an average medium time to heal of 76 days. However, if the wound was debrided at least once a week, the wound went on to heal in 21 days. And the same goes for surgical wounds. I have worked clinically in primary care while I've been in this role, and there has been a few surgical wounds that have come to me that have dehisced, and the healing time has increased, and they have had better results through wound preparation, wound assessment, wound preparation, and the appropriate treatment outcomes. Next slide, please. So holistic assessment directs wound preparation that includes washing, cleansing and debridement. So you want to be washing the surrounding skin as well. Even in a surgical wound, you want to be getting to that peri-wound skin, especially if it is kind of on the abdomen and close to a potential stomastite. There are different types of debridement. You've got your autolytic debridement, which is your body's attempt to shed the devitalized tissue and moisture naturally. You've got mechanical debridement, which is the physical removal of devitalized tissue using friction. You've got biological, which is your maggots, which you in a surgical wound would probably be quite rare. It used to happen quite a lot with vascular surgery, but usually in the acute. But it's normally your chronic wounds that tend to kind of go for your larva or your maggot therapy. And then you've got your enzymatic debridement, which is where you'd use an ointment or a gel to soften and lift any necrotic tissue. And then finally, you've got your surgical or sharp debridement, which will then, in theory, cause, if you've had your surgical debridement, would then leave you with a surgical wound. Normally, after surgical debridement, you do have a nice clean wound bed and wound edge to kind of work with, because the whole purpose of them taking them to theatre would be to get really good margins and help remove any devitalized tissue further out. Next slide, please. The international best practice for management of biofilms and infection is wound preparation. The management of biofilms must recognise there is no one-step solution. Different treatment strategies can be used. So you want to be doing your wound preparation. You want to be cleansing and debriding to remove the number of microorganisms by disturbing and removing some of the biofilm. So you want to be going over with something like an all prep pad and cleaning over it, even if the surgical wound is closed. It still doesn't mean that it's totally free from wound infection because of the nature of what's on our skin. Next slide, please. So the aim of wound preparation is to accelerate healing or to facilitate the effectiveness and management and treatment plans. It is an approach that should be undertaken at each wound care intervention. So every time that you are changing a dressing or for a surgical wound, you want to be doing an assessment. You want to be using your clinical judgment, re-evaluate what your treatment goals are and think of the patient's pain levels. With all that in mind, you then want to kind of be moving on to your wound preparation. So your assessment would identify if there's any devitalized tissue there. Your clinical judgment will determine kind of what level of wound preparation is required. And obviously your overall treatment goal, it would be to, in theory, heal the wound. So you want to be then thinking of how you're then going to prepare. The same goes for surgical wounds, even though you might not dress the wound as much as you would with maybe something a little bit more hard to heal, you still would be doing wound preparation at each dressing change. Next slide, please. There are times when we need to be cautious with wound preparation, and this is the same for wounds that are surgical in nature. So if a patient has had a surgery and it's caused a wound on the lower limb, if you know this patient is diabetic, you maybe want to have some caution and maybe seek some specialist advice. If you know that the patient's got an arterial flow concern or poor localized tissue perfusion, if the patient's on any certain medications or has any underlying medical conditions, if they're on psychotoxic medication or immunosuppressed, you maybe want to use with caution and get some specialist advice and follow kind of tissue viability or the surgeon's advice prior to it. You also wouldn't use wound preparation in a surgical wound if you've got kind of exposed organs, and that goes back to your National Wound Care Strategy programme red flags. In them cases where you've got exposed organs, it will literally just be a case of kind of an emergency procedure, holding everything in, getting the paramedics there and blue light into the acute services. Next slide, please. So we've done assess, we've looked at the whole wound and we've looked at the whole patient. We've identified some treatment objectives that we want to do. We've then done step 2, which is our prepare. So we'll move on to step 3, which is treat. Next slide. Next slide again. So we want to identify our treatment objectives. So the wound assessment and the wound preparation leads to identification of these objectives. We should support the optimum healing environment for the wound. So whatever we decide to do should provide that wound with the right environment in order to allow it to heal. So we want to be looking at things like exudate or exudate pooling, especially if the wound has dehisced. We want to be protecting that peri-wound skin so the wound doesn't break down further or increase any infections. We want to also look at any maceration or excoriation. We need to consider the depth or the cavity that there is to the wound, because that'll also determine our treatment choice as well. Do we need to have a filler or not? And we'll come to that further on. And is there any infection or any biofilm that we need to consider when we need to treat? Dressing selection plays an important role in surgical wound management and can help prevent and minimize risk. To improve the outcomes of incision care, consideration needs to be given to the surgery type, the wound status, and individual patient circumstances. So different surgeries require different treatments, but that should all be identified in your aftercare. So plastics usually like a certain wounds to be treated a certain way, especially in skin grafts. So you really need to be following their treatment plan. And if there's any issues, if you identify anything that kind of would deviate, you need to deviate from that, I would recommend going back to the plastic surgeon to see how they want to take it further. Next slide, please. So dressing choices. If we've got a dehisced wound, we need to firstly refer back to our National Wound Care Strategy Programme red flags. If it is a large dehiscence, we need to seek immediate advice from a clinical decision maker, or we obviously need to be looking at an emergency response if there's organs involved. If you haven't got that emergency or immediate review, we then really need to be looking at the wound depth first of all. How deep does the dehiscence go? What is the exudate level that is coming from this as well? And is there any tunneling or undermining as well? Once we've kind of factored in all that, we can then look to see if the patient's in any pain. Do they need any kind of pain relief alongside what we're going to treat for the wound? If your wound has dehisced and you've also got a surgical site infection, again, you want to be referring back to your National Wound Care Strategy Programme red flags and seek immediate advice or an emergency response if that needs be. And then if there isn't any, if there's no red flags, we can then move on. We look at the same things that we would do if the wound had dehisced, but we need to be thinking of what antimicrobial we're going to be using to kind of combat that surgical site infection. And then if the wound hasn't dehisced, if it is just closed, but there is signs of a surgical site infection, we do need to do a microbiology swab, which will help with the surgical site infection reporting, because we do need to know what bugs have actually caused that infection. And if, like we said, it's still intact, so we just need to factor in what antimicrobial we're going to use on the wound. Next slide, please. So when would we implement an antimicrobial? So if we look at our wound infection continuum, we've got contamination, colonization, local infection, spreading infections, systemic infection. So at contamination and colonization, we wouldn't be looking at implementing an antimicrobial. We want to be doing it at local infection and kind of treating it at the source. Once we kind of get to spreading or systemic infection, that's when we kind of need topical antimicrobials, but we also maybe need something more along the lines of an oral or IV antibiotic. Next slide, please. So as I said, when we're kind of in the contamination colonization stages, we do not need to use a topical antimicrobial. They're not indicated. There's always kind of bacteria and things in our wounds, but at this point they're not causing an issue where we need to be doing something about them. We just need to be keeping an eye, making sure we're doing our assessments thoroughly. Next slide, please. Next slide, please. So as I said, local infection, the bugs, the bacteria levels and the numbers have started to increase. We've now got them signs of infection. So this is where we would be using a topical antimicrobial dressing. At this point, you shouldn't need an antibiotic. You should be able to just manage with an antimicrobial and review. Next slide, please. And here, when we get to you spreading and systematic infections, you want to be using antibiotics and an antimicrobial dressing. But in regards to a surgical wound, at this point, you would have identified these. These would have flagged on your red flags, and you'd be kind of looking for your surgical reviews anyway. Next slide, please. Topical antimicrobials come in different forms, and depending on kind of what you identify in your assess stage and what your treatment objectives are, will determine which ones you're kind of going to use in your treat. So they come in liquids, pastes, creams, ointments, sprays, impregnated dressings, you name it, there is probably an antimicrobial dressing in that form. Each product will be used differently, and how frequent they should be used also then depends on the product. So some can be used every day and will be just used for a certain period of time. There's one out there on the market that you know you can only use for the wound for 20 minutes and then you can't use it again for so many days, whereas you've got others like Biotin Silicon AG where you can leave on the wound for 7 days. So there are different types. So you've got your main ones that you'll probably see are your honey, your PHMB, your iodine and your silver. Next slide, please. Silver has been around for thousands of years in wound care to prevent and treat infections, and it's probably the most common one that you're probably going to use on your surgical wound, especially if you've got a closed wound that you just want in a dressing to go over the top. It has been available in your solid elemental forms. It can be found in a silver solution as a salt, and you can find it in creams and ointments. In recent years, a wide range of wound dressings containing silver have been developed, and they are easy to apply and provide a sustained release of silver and need less frequent dressing changes. Like I just said with the Biotin Silicon AG, it can stay on for 7 days and has that prolonged release over that 7 days. Silver does have a broad spectrum antimicrobial effect against bacteria for both gram-negative and gram-positive. And silver has shown to prevent biofilm formation in vitro studies. So if you go back to your prepare stage, you've disrupted your biofilm. You then want a dressing to stop that biofilm from growing back, and your silver dressings are the way to do that. Next slide, please. Silver targets multiple sites in bacteria, so silver ions bind to the bacterial cell wall, blocking transport of substances in and out of the cell, so they stop the messages getting in and out. Silver ions are transported back into the bacteria cell wall. They'll block the respiratory system, destroying energy production, so they kind of start suffocating the bacteria cell in theory. And then in the bacterial, silver cell ions interact with the DNA and inhibit the cell bacteria division and stop them replicating. So they kind of go in and suffocate them and then stop them being able to multiply and breed. Next slide, please. So international best practice for the management of biofilms and infection, we do say it's not a one, as I said before, it's not a one-step solution. There are different strategies that should be used. So we covered wound preparation in our prepare section of the webinar. So you've done your wound preparation, you then want to stop them growing back. So you want to be applying a dressing that prevents maceration, that helps management of exudate and helps prevent recontamination. You then also want to look at your infection management. So you've got a biofilm, there's probably a high chance that there's also an infection there. So you want to be suppressing that biofilm formation and reducing the existing biofilms and microorganisms with an active agent such as your silver, like I discussed before. Next slide, please. With antimicrobials, we want to be using them appropriately. We want to be looking at antimicrobial stewardship. So we do suggest that we look at the 2-week challenge. So the duration of an antimicrobial should use should be based on individual assessment, and you should have a regular wound assessment. And it's been suggested that you do a 2-week challenge to determine the clinical efficacy of silver dressings. After this period, the wound, the patient, and the management protocol can be re-evaluated according to the figure. So you've assessed your wound, you've prepared it, you're now onto your treat. You then want to you've got a surgical site infection, so you want to be implementing something like a silver for 2 weeks. If you've got no improvement after that 2 weeks, the silver dressing should be discontinued and consideration should be given to change into a different antimicrobial agent. So there might be something going on there that requires something a bit more specific to target the bacteria that is growing on your surgical wound. If you've got improvement and you've got no signs of infection, your silver treatment can be discontinued and you can step down to just your normal dressings and look at different approaches to healing. If you've got improvement but you do still have signs of infection, treatment with the silver can be continued with regular reviews. Next slide, please. Next slide, please. So we've discussed the Coloplast 3-step approach in relation to your wound your surgical wounds. So step 1, you want to be assessing, have you got a surgical site infection? Have you got any wound dehiscence? What was the nature of the surgery in the first place? And also your patient factors that would form your holistic assessment. In your prepare stage, you want to be removing them physical barriers to healing. Even if it's closed by primary intention, you still want to be making sure that nothing can kind of cause that to break down. And step 3, you treat. What have you identified in your wound assessment and your wound preparation stages, and what are your objectives and your to healing that would then result in what you're going to use in your portfolio for your treat section. Next slide, please. So this is just a case study and what's actually happened in clinical practice. So this was a 55-year-old patient who had a big toe amputation due to type 2 diabetes and arterial insufficiency. He was having multiple dressings, daily dressings, to try and manage the exudate levels. So in the assessment where the management goals were identified, you want to be creating an optimal healing environment by preparing the wound bed, the wound edge, and the peri-wound skin. We need to be, as you can see on kind of day 1, you can see that there's devitalized tissue there. The wound edge is quite macerated because of the exudate levels, and you can see evidence of granulation tissue and epithelial tissue. So we really want to be protecting that, and we want to be protecting the peri-wound skin. So obviously you want to be using something like All Prep Pad to prepare to get rid of that devitalized tissue to help promote that granulation tissue from coming through and protecting the peri-wound skin. And then treat, you can kind of see because of the increased exudate levels, there's you would assume that there would be an infection there. So we want to be looking at something like biotin, silicon AG. And as you can see from the photos, by week 9, obviously we've got nice healing, granulation and epithelial tissue there. And you can see the wound coming together nicely. And by week 14, it's almost there, it's almost healed. So for this, the results for this case study, the wound had decreased in size from 18 centimetres by 7 centimetres to 4 centimetres by 1 centimetre in 14 weeks. So it just goes back to the Wilcox study. It shows if you use wound preparation, get rid of all that devitalized tissue, we can have better healing times. The top of the wound where the toe was has now healed. So it's just the side that's left to kind of go. The exudate levels to the remaining open area are low. There's no signs of infection, and the patient's pain score was 2 out of 10. The wound was no longer requiring antimicrobial to manage the bacterial load, and it was being treated with biotin silicon. So we've been able to utilize that 2-step challenge and step down to just a biotin silicon rather than a biotin silicon AG. Next slide, please. So this is just our pathway for your non-healing surgical wounds. So you want to be doing your assessment, complete your holistic assessment and your wound assessment using the triangle. You want to be looking for identify your red flags, which are there down the side. So for red flags 1 and 2, you want to be seeking immediate review and follow the instructions and the guidance from the senior clinical decision maker. So at that point, you would kind of stop on the pathway, follow their guidance and their advice because of the nature of the red flags. For red flags 3 and 4, you would then continue to follow the pathway until the patient is reviewed by the surgical team. If you don't have any of the red flags, you will then refer to your local policies and procedures for any escalations or concerns. So, like I said, we need to be reporting all of our surgical site infections. If you don't have any of the red flags, you then want to be preparing your wound for healing. You want to be recording your wound dimensions. So that is your wound length, width and depth. And then you want to be treating depending on your objectives that you identified in the assessment stage. And then you want to reassess and go back round. Next slide, please. We also have our simplified product choice. So you've done step 1, you've assessed using the pathway. Step 2, you've used your oil prep pad or you followed your local guidance to prepare that wound, get rid of any devitalized tissue. Step 3, you then want to be kind of going on to as you treat. So if you've got an infection present, if the wound hasn't dehissed and you've still got your primary closure, or if it's dehissed but less than 2 centimeters, but there's no signs of infection, you can use your Biotane silicone. If it has dehissed and it is deeper than your 2 centimeters, or you've got any undermine or tunneling, you can use your Biotane fibre and then your Biotane silicone on top of that. If you do have infection present, again, if the wound is less than 2 centimeters, or it's dehissed less than 2 centimeters, you can use your Biotane silicone AG because of the 3D fit. It will mold to the wound bed, so you will not need that filler. If you have got infection present but it's dehissed further down than 2 centimeters, or you have undermining and tunneling, you want to be looking at your Biotane alginate AG and then your Biotane silicone until you get that depth up. Next slide, please. If you want any additional support for products and our services, you can scan the QR code there and contact one of our team in the office, and they can discuss anything further with you, or you can contact your local Coloplast territory manager. Next slide, please. We do have some podcasts available through our Wound Care Conversations where you'll hear Sam, who is on the chat, discussing various other topics and walking you through. So we've got podcasts on our assess, prepare, treat. We've got assessments or podcasts on wound infection, pressure ulcers, leg ulcers and supported self-management, and they're available on Apple Podcasts, Spotify, Google Podcasts and more. And if you want any further information on any of our future webinars, again, you can scan the QR code at the side there. Next slide, please. And that's everything from us today. Thank you everyone for listening. Is there any questions in the chat, or anyone want to come on the microphone and say anything?
Hi Kirsty, well done. That was really good. We've had a little bit on in the chat just asking about overgranulation, which I answered, but they were quite quiet. So
okay.
No, nothing else to look at unless anyone's got anything to ask now. But well done, Kirsty.
No, well, if no one's got any questions, thank you everyone for joining the webinar.